Welcome back and thanks for joining me for fetal assessment during labor. As a labor nurse, we're trained to assess fetal heart tones and interpret the response of those fetal heart tones during contractions. So it's that relationship of the fetal heart tone during the contraction that create these fetal heart tone patterns that we interpret as how the baby's doing. Abnormal fetal heart rate patterns, or also known as Category 3, are associated with fetal hypoxemia, and if uncorrected, it can lead to fetal hypoxia, which results in metabolic acidosis. The term asphyxia is used when hypoxia results in metabolic acidosis. Please review in your textbook the three-tier fetal heart rate classification system of Category 1, 2, and 3. You don't need to memorize all of these, but have a general understanding that there are three categories, with Category 1 being normal, reflecting that the fetus is well oxygenated. We also call this category a reassuring fetal heart rate pattern. Category 2 is indeterminate, meaning that the fetal heart rate isn't great, but not horrible yet. Interventions are necessary to prevent the fetal heart rate pattern from deteriorating into a Category 3 issue. Kind of the goal of fetal heart monitoring is to interpret, as I mentioned, but also to kind of decide if it's reassuring or a non-reassuring pattern. Your textbook stated it well, so all of the information I'm reading in this slide is on page 382 and 383 from your textbook. Labor is physiologically very stressful on the fetus, so part of the role of the RN in labor and birth is to monitor the fetal status. Fetal oxygen supply must be maintained during labor to prevent fetal compromise and to promote newborn health after birth. The ways that fetal oxygen supply can decrease are by a reduction of blood flow through the maternal vessels as a result of maternal hypertension, hypotension, that can be caused by supine maternal position, hemorrhage, epidural analgesia, or anesthesia. Also by a reduction of the oxygen content in the maternal blood as a result of hemorrhage or severe anemia. By alterations in fetal circulation occurring with the compression from the umbilical cord prolapsing outside of the uterus before the baby's born, or a partial placenta separation or complete abruption. Now I realize you may not have had those terms yet, but hopefully this big picture will come together and you'll start to understand some of these. Or also alteration in fetal circulation because of head compression. Head compression is when the uterus contracts, it pushes that baby's head against the cervix to thin it and dilate it. But that head compression causes increased intracranial pressure, and that results in vagal nerve stimulation, causing a decrease in fetal heart rate. But what's imperative with head compression is that when that contraction's over, that head should be lifted off the cervix and normal blood flow should take place, and then it will promote fetal heart tones back to the normal range. Oxygen supply can also decrease by a reduction in blood flow to the intravillous space in the placenta secondary to uterine hypertonus, usually caused by administering too much Pitocin, or secondary to an aging placenta associated with maternal hypertension and diabetes. Your clinical instructors should know a great deal about this as well as your theory instructors, so if you have any questions, don't hesitate to ask any of us. These are some of the topics we're going to talk about for fetal assessment during labor. What is the fetal heart rate baseline? The types of fetal heart rate patterns that we're looking at. And remember, the patterns, we're looking at the fetal heart rate and what it does when they're having contractions, when the patient's having contractions. So variability, accelerations, late decelerations, early decelerations, variable decelerations, or prolonged decelerations. And we will explain uterine activity. Okay, so now I'd like to help you understand that the normal fetal heart rate baseline is between 110 and 160 beats per minute. Fetal tachycardia is defined as the fetal heart rate over 160 beats per minute, but it has to last longer than 10 minutes. Fetal bradycardia is the fetal heart rate less than 110 beats per minute lasting 10 minutes or longer. So the mean fetal heart rate is rounded to increments of 5 beats per minute during a 10-minute segment. And that sounds a little confusing, but as an example, if the fetal heart rate range over a 10-minute period in between contractions is 130 to 140 beats per minute, we would document it as 135. So you're taking the average in increments of 5 and documenting that, as opposed to years ago we used to document it as a range. Okay, so as we look at this slide, we need to determine the fetal heart rate range, and we know that normal is 110 to 160, but we want to determine this baseline in between contractions. So if you look at the blue arrow, that's kind of where I'm looking right now, and I'd say it looks like it's around 118 to 128, or in some spots 120 to 130. So as I'm documenting it, let's just say the fetal heart rate baseline is 120 to 130, the range, a 10 beat range, and we're going to document it as 125 beats per minute. Now this slide shows two different tracings, fetal monitor tracings, and the one on the left is tachycardia, and I know it's kind of difficult to see, but that's kind of a baseline, and we're looking in between the contractions, and you can see that's what it looks like. It's elevated. It doesn't have a huge range, but it does have a little bit of, maybe it goes from 175 to 185 in some spots, and so, but we're going to call it 180 beats per minute. And remember, tachycardia or bradycardia are defined for the fetal heart rate tracings over 160 or under 110, and that's over a 10-minute period of monitor strip. And on the right-hand side, you can see this doesn't look very promising. This is, we have it originally about 80 beats per minute, then drops down to 60 beats per minute. Both can be kind of ominous. Some of the causes of fetal tachycardia, which would be greater than 160 for a period of 10 minutes, could be early fetal hypoxia. If the mom has a fever, that's one of the number one things we think about as soon as we see any tachycardia. Maternal dehydration, amnionitis, maternal hyperthyroidism, beta sympathomimetic drugs, fetal anemia. So if fetal tachycardia is accompanied by late decelerations, severe variable decelerations, or absent or minimal variability that we'll talk about in a few minutes, again, it's even more ominous. Fetal bradycardia is caused by profound hypoxia in the fetus, maternal hypotension, prolonged umbilical compression, fetal arrhythmias, uterine hyperstimulation, so that's when there's too many contractions and not enough breaks in between contractions, abruptio placentae, uterine rupture, so that means when the wall of the uterus actually ruptures, and vaginal stimulation in the second stage of labor. So that's touching the baby's head. It can sometimes cause a vagal response and cause that heart rate to go down. Now I'd like to talk to you about uterine contractions. So normal uterine contraction activity during labor. Why is this important? Because in order to determine the fetal heart rate pattern, we want to look at that in relationship to the uterine contractions. But in order to understand that, we need to look at several different variables within those contractions. So we want to know about the frequency of the contractions. How often are they occurring? So in this picture over to the right, or in this diagram, frequency is from the beginning of one contraction to the beginning of the next contraction. So as you're looking at it from point A to point C on this slide. So if someone comes in and says my contractions are 3 minutes apart, if I were to look at the monitor strip, I'd start counting the beginning of the first contraction and then how many minutes until the second contraction starts. Duration is the time from the beginning of one contraction until the end of that contraction. How long does that contraction last? So on this slide, it's point A to point B. Now on your fetal monitor strip, this time frame is represented by 10-second little boxes. The intensity is the strength of the contraction. With external monitor, it's palpated. So if you'll do me a favor and put your index finger on the tip of your nose and push in. Then I'd like you to do the same thing, touch your chin, and then touch your forehead. So as you touch your nose, if we were to lay our hand on the mom's contracted uterus or on her belly, it would feel like mild if we could push down a little bit like it does on your nose till we get to the cartilage. As we're pushing on your chin, that would be a moderate contraction, and as we're pushing on your forehead, that would represent a strong contraction. With internal monitoring, we use an intrauterine pressure catheter, which has a pressure-sensitive tip and captures the pressure in millimeters of mercury. As that uterus contracts, it compresses that pressure-sensitive tip. After the contraction subsides, the tip measures the resting tone, or basically the uterus at rest with no pressure being exerted upon the baby. This is indicated on point B to point C, the resting tone. That's in between contractions. And as we're also looking at the slide regarding the strength of the contractions, the increment is as that contraction grows, kind of like on a roller coaster as you're going up to the top. The acme is the peak of the contraction, and the decrement is as it's coming down. So as you're coaching someone through labor, it's always kind of nice. You don't need to tell them that it keeps getting worse, but as it starts to make that curve over the top, you want to say, okay, it's not going to get worse. Just keep doing your slow breathing, and you kind of coach them through so psychologically the patient knows that contraction is not going to get any worse. And then the Montevideo units, they're used to measure the intensity of contractions in a 10-minute period. It can only be calculated with the internal pressure catheter in place. And remember, to have that internal pressure catheter in place, the mom's bag of waters has to be broken. So if we're looking at normal uterine activity, and we look at this strip, on the top represents the fetal heart rate tracing, and on the bottom it represents the contraction pattern. And each of those little squares on the bottom represent 10-second increments. The dark red lines represent 1-minute increments, or 6 little boxes. So when I say, what is the frequency? Contraction frequency are every 2 to 2.5 minutes. The duration, the contractions last on average about 70 seconds long. The resting tone, if this were an intrauterine pressure catheter, is about 15 millimeters of mercury. And as we look up at the baseline range, we're going to say it's about 120 to 130, a term we're going to learn about in a minute, moderate variability. And I would document it at 125 because I'm looking at it again in between contractions. And a bonus question, can you identify this fetal heart rate pattern? Actually, the bonus question was, what is the baseline? But can you identify any fetal heart rate pattern? In order to do that, I'm looking in between contractions. I'm getting that baseline, about a 120 to 130. But right as that contraction starts, you'll notice that those heart tones come down a little bit. They drop down even to about 100, between 100 and 110. But by the end of that contraction, it's back up to the baseline of 120. So as you will learn in a few minutes, that's called an early deceleration. It's caused from head compression, fetal head compression against the cervix, and no intervention is necessary. It's a normal finding during labor. Okay, as I look at this monitor tracing, I'm noticing, does anything stand out? It looks like the heart tones are within the normal range of 110 to 160. These look at they're around 120 to 140 at times. But boy, look at all those uterine contractions. This is a 10-minute period of fetal heart rate tracing or recording. So in order to see if this is too many contractions, sometimes we worry that if the contractions are too strong, it puts too much pressure on the baby and can cause the baby to be hypoxic. And as that uterus contracts normally, it creates kind of a hypoxic environment. So we want to make sure that too many contractions aren't occurring. That term is called tachysystole, which is greater than 5 contractions in a 10-minute period. Now we have the advantage in this particular tracing of using an intrauterine pressure catheter monitor, which is very important. So we're going to look at the peak of the contraction and calculate that out, and then we're going to subtract that resting tone. Now I've averaged some of these, so they're not 100% perfect, but this again is an estimate. So Montevideo units are used to calculate the strength of uterine contractions, to evaluate the adequacy of the uterine contractions achieving the progress in labor. So we want to maybe capture these if we're inducing a patient with Pitocin, and we want to see if these contractions are actually adequate, or if we maybe need to increase our Pitocin if they're not adequate. Our goal is to have 100 to 250 Montevideo units in the first stage of labor, 300 to 400 during the second stage or the pushing stage of labor. So if we're under our goal of 100 in a 10-minute tracing, then we might want to consider increasing the Pitocin. But in this particular tracing that I'm looking at right in front of you, we're going to take the first contraction, which measures at about 80, maybe a little bit more than that, but we'll say 80, and we'll subtract the resting tone. And I've decided to use the average of 25 for this 10-minute tracing for the resting tone. Remember, that's where the contractions come down to baseline. So that's the period when they're not contracting, so it's around 25. So we're going to take the peak, 80, minus 25. The second contraction is around 60 minus 25, and on and on and on. Now these numbers may not match your calculations exactly, but that's not what I'm trying to prove here. I just want to give you an idea of how they calculate. And with this calculation, I've come to 320 Montevideo units. So if this patient is in the first stage of labor, or if she's being induced, 320 Montevideo units is too strong because our goal is 100 to 250 in the first stage. And she's also having tachysystole, which is greater than 5 contractions in a 10-minute period. There's 6 up here, 1, 2, 3, 4, 5, 6, 7 actually on this tracing. So we would definitely want to back down on the Pitocin, probably cut that Pitocin drip in half in terms of the rate at which we're infusing. And we'd want to reevaluate. Now, so far, having too many contractions with that strength of contractions hasn't hurt the fetal heart rate because it's still within the normal range. But over a period of time, persistent tachysystole can definitely affect the fetal heart rate in an ominous manner. Now, some of the other terms you need to know about are variability, accelerations, late decelerations, early decelerations, and variable decelerations, or prolonged decelerations. So variability within the fetal heart rate. So the term variability is actually a fluctuation in the fetal heart rate baseline that are irregular in their amplitude and frequency. So if we're looking at a fetal heart rate tracing, which we will in just a minute, you'll notice that you see a wavy line. If I said the baseline range, normal we know is 110 to 160, but let's just say it's 120 to 130. How I get that range is little up and down movements. Well, the upper end is the sympathetic response, which is speedy, sympathetic speedy, parasympathetic pokey. And it's the sympathetic and parasympathetic working together. That's the autonomic nervous system. And if we have that moderate baseline range, anywhere from 6 to 25 beats per minute, that tells us that that baby is neurologically intact. Okay? Neurologically intact means that it's probably well oxygenated and the amplitude is within 6 to 25 beats per minute. So normal is under the category of moderate, but we can classify the variability or the variability baseline range as absent, minimal, which is undetectable from the baseline, or less than 5 beats per minute. Moderate is 6 to 25 beat range, and marked is greater than 25 beats per minute. So here on the upper left, you'll see that it's minimal. The range is not easily to detect. But this center picture, you'll see the peak and the trough. And then the higher end is the sympathetic or speedy, parasympathetic pokey. Those working together with the peak and the troughs give us that range. So as I mentioned, absent is undetectable from the baseline. There's hardly any range, maybe just a little bit there. Minimal, down below, it's undetectable to around 5 beats, less than 5 beats per minute. Moderate is 6 to 25 beats per minute in the upper right, and that's a positive sign. That's a reassuring sign. And marked, greater than 25 beats, greater than or equal to 25 beats. You see how that's all over the place? That can be the result of an insult or a hypoxic event to the baby. So we really don't want it to stay marked like that. Okay, that really should say greater than 25 beats per minute instead of greater than or equal to. All right, but here we could say that the baseline range on this marked is 130 to 145, but then you see up and down, up and down, up and down, up and down. That's kind of an ominous sign. That means that fetal hypoxia probably has just occurred. So we're going to watch this very, very carefully. So I'd like to talk to you about some reassuring heart patterns. The fetal heart rate pattern accelerations. Accelerations are an abrupt increase of at least 15 beats per minute in a fetal heart rate above baseline, lasting at least 15 seconds in a 32-week gestation until term fetus. So basically, if we looked at this baseline, now you really can't see your contractions, so if you look down at the bottom part, you can't see where your contractions are. So we're just going to look at this baseline. And it's about 130 to 150, which is pretty kind of all over there. But all of a sudden you'll see it shoot up to 175, and we want it to be at least 15 beats. So if we say the baseline's 130 to 150, we want that to get to at least 165, so 15 beats above the baseline, and it needs to last at least 15 seconds. And this one lasts about 60 seconds, 50 to 60 seconds. So, and it goes above the baseline for about 10, 20, 30, about 40 seconds. So that's fantastic. So this would be a healthy sign. This tells us that the baby has great oxygen stores and everything looks terrific. In pregnancies less than 32 weeks, the baby's not quite as mature, so accelerations are defined as an increase of 10 beats per minute lasting at least 10 seconds. So we'll settle for something not quite as long and not quite as tall, basically, if the baby's premature. Okay. When I gave you that little quiz a minute ago, I was talking about head compression and early decelerations. So early decelerations are a gradual deceleration in fetal heart rate, beginning at the onset of a contraction with a return to baseline by the end of the contraction. It mirrors the timing of the contraction. The causes include uterine contractions, vaginal exams, fundal pressure, and placement of the internal monitors. Remember that the uterus is a big muscle, and as that uterus contracts, it pushes the baby's head against the cervix, causing a vagal response in the fetus, which lowers the baby's fetal heart rate. After the contraction lets up, the head is no longer pushed against the cervix, and the fetal heart rate returns to baseline. And you'll notice by the red the red arrows, when the contraction is just beginning, it causes that decrease in the fetal heart rate. But by the end of that contraction, again, the pressure's off the head, the fetal heart rate comes back. And it's kind of a saucer shape and kind of uniform. And it takes about 30 seconds to get down to the lowest part of the nadir of that fetal heart tone deceleration. And you see the peak of the contraction is right in line with the lowest part of the deceleration. Those are characteristics of earlies. And here's just another example. You see how it's kind of smooth, saucer shape? And by the end of that contraction, if you draw a line through that all the way up to the top, the fetal heart tones are back up to the baseline. Now for some non-reassuring fetal heart rate patterns. Isn't that a cute baby?
Okay, as we look at this next tracing, we're looking at late deceleration. So a late deceleration is the deceleration of the fetal heart rate that begins after the contraction starts, with the nadir, or the lowest part of the deceleration, occurring after the peak of the contraction, and it returns to baseline after the end of the contraction. This is caused by uteroplacental insufficiency. And some of those causes include uterine tachysystole, which we talked about a few minutes ago, maternal supine hypotension, epidural or spinal anesthesia sometimes, placenta previa, placental abruption, hypertensive disorders, post-maturity, intrauterine growth restriction, diabetes mellitus, or intraamniotic infection. All of those can affect the blood flow coming from the placenta to the uterus. If you'll notice, just look at this, you can kind of see where the classic sign is at the peak of the contraction that late deceleration starts. And about 20 seconds after that peak, you'll notice that the lowest part of the deceleration in the fetal heart rate tracing is there. And by the end of the contraction, it's not quite recovered. It's late to recover and get back up to the baseline. In this tracing, it's 150.
This is another example of late decelerations. Again, if a patient has one late deceleration, or even just every once in a while, it's not as concerning. But as you're looking at this fetal monitor tracing, the variability is really only, the range is only about 5. So this would be called minimal variability, which is a little bit more ominous. And then we have these, with every contraction, we're having a late deceleration. So I think when they're looking at I don't know if it's a 20 or 30-minute strip, if 50% of the contractions have late decelerations associated with them, it's considered a very ominous sign. And they may want to look at trying to get that baby out or some drastic interventions.
So variable decelerations are defined as an abrupt decrease in the fetal heart rate below the baseline, which may or may not be associated with uterine contractions. The onset to the beginning of the nadir, or the lowest point of that fetal heart rate, is less than 30 seconds. So this is an abrupt deceleration, whereas the earlies and late decelerations are more saucer shaped and they take about 30 seconds to get to the lowest point. But variables, the appearance of variable decelerations differ from those in early and lates. Their variables are usually U, V, or W shaped. Occasional variables aren't much of a concern, but reoccurring or deep variables, deep meaning how low the actual nadir is, how low the heart rate drops, indicate a disruption in the oxygen supply to the fetus. And variables can occur in about 50% of labors, and they're usually correctable, but it's directly related to umbilical cord compression. Sometimes that's a cord around the neck, sometimes it's a short cord, or sometimes it's just the position the mom's in and she needs to change her position. Here's another example of variable decelerations. You can see the variability, or the range isn't in the fetal heart rate. It is between, it's higher than 110. Looks like we have some fetal tachycardia here. In between contractions, you can see that rate is around 170 to 175. So that's kind of high. We don't want it above 160. But we also see these are V-shaped variable decelerations. And you can see the second major one dips down very low. It dips down to about 70, 65 to 70. And so that one's going to be a little bit more ominous, or not as comforting. Okay, but these ones are occurring with contractions. So we just want to take note of that. Some causes of umbilical cord compression are the maternal position. It may have the cord between the fetus and the maternal pelvis. So that's one where you'd want to reposition the mom to see if we can improve those variables. It may be the cord around the neck, as I mentioned, arm, leg, other body part. It could be a short cord, a knot in the cord. or a prolapsed umbilical cord. That means it's coming out through the opening of the vagina and the head possibly has compressed against the cervix, so cutting off its own oxygen. Your In your text in box 15-4, you'll notice some interventions. So we want to change our maternal position, go side to side, or flip the mom over and go put her in knee chest position. We may want to discontinue oxytocin if it's infusing. We might administer 8 to 10 liters of oxygen via a non-rebreather mask. We want to notify the physician or midwife. If we're concerned about cord prolapse, we may want to assist with the vaginal speculum exam to assess for that. We want to assist with the amnio infusion if there's not enough fluid because too much fluid is leaked out, causing cord compression. Or if it looks like birth is imminent, we're going to assist with birth, vaginal assisted or cesarean, if the pattern can't be corrected. Now, amnio infusion is an infusion of room temperature isotonic solution, either lactated ringers or normal saline. The infusion is administered through an intrauterine pressure catheter with the initial bolus over 20 to 30 minutes and then set to a maintenance rate. Amniotic fluid buffers the umbilical cord, but occasionally after the bag of water breaks, the cord loses its buffer from the umbilical cord and it becomes compressed. So amniocentesis restores some of the fluid into the uterus and ideally the variable D cells will decrease. So again, that's called an amnio infusion. Not amniocentesis. Sorry about that. I meant amnio infusion.
And this is something called a prolonged deceleration. That's defined as a decrease in the fetal heart rate below the baseline. The decrease in the fetal heart rate is 15 beats or more and lasts for at least 2 minutes but less than 10 minutes from onset or return to baseline. A prolonged deceleration that lasts more than 10 minutes is a change in the baseline, and that's probably going to be called bradycardia. But if it's from 2 minutes to 10 minutes, a deceleration, then it's going to be called a prolonged deceleration. And this can be an ominous sign as well.
Okay, now the sinusoidal pattern. This looks kind of benign when you first look at it, but it's a wave-like pattern, undulating wave-like pattern. And it actually falls under the category 3 or the ominous category, and is described as a smooth sine wave-like undulating pattern with a cycle frequency of 3 to 5 beats per minute that continue for at least 20 minutes or more. This tracing represents an abnormal acid-base balance at the time it is observed. Its known causes are chronic fetal anemia associated with erythroblastosis fetalis, usually from Rh sensitization, acute intrapartum asphyxia, fetal maternal hemorrhage, or in utero fetal hemorrhage. At times, I've seen a pseudo-sinusoidal that occurs after a narcotic analgesia was administered to the mom, so something like a Stadol. But that fetal heart rate pattern went away as the medicine wore off. But true sinusoidal is an ominous sign that something very bad is wrong with the baby.
Okay, so this is the classification system. Again, I'm going to have you look at the monograph that I've attached under the TechSmith videos, but it's actually a paper document. And it talks about category 1 is normal, category 2 is indeterminate, heading towards abnormal, but we need to do some interventions. And then category 3 is abnormal, showing that the baby could be getting hypoxic. We're going to talk briefly about some intrauterine resuscitation measures. And then when you're talking about communication of electronic fetal heart monitoring data, that's when you're talking to the physician, and that's why we're all on board to use the same language. It has to do, everyone's calling the fetal heart rates the same things. We're averaging the fetal heart rate baseline range, and we're giving it in increments of 5. And we want to know what factors are affecting the fetal heart rate, and those are some of the things that I've talked about throughout this lecture.